We'll get started now. I think that's everybody. So hi, everyone. Welcome to our webinar today of Pain and Parkinson's. We're very happy to welcome back Dr. Bruno. My name is Emma, and I'm the Client Service Coordinator in the Calgary region. If you have any questions during the webinar, feel free to enter them into the chat. So there is a little chat icon in the bottom menu, and you are welcome to put your questions in there throughout the webinar, and then we will get them answered at the end. Just as a disclaimer, this webinar will be recorded. All of the information provided in the videos by the Parkinson Association and our featured guest speaker are strictly furnished for educational and entertainment purposes only. The service is not intended to be diagnostic, prescriptive, or replace the relationship and/or advice of your physician. General questions about symptoms and treatment options will be fielded. So just as an introduction for our speaker today, we have Dr. Bruno, and she is a neurologist here in Calgary with a subspecialty in movement disorders. She received her medical degree and neurology residency in Argentina. She completed her fellowship in movement disorders at the University of Toronto and a Master's of Public Health degree at Harvard School of Public Health. Dr. Bruno's primary interest is in the treatment of advanced Parkinson's disease, with a particular interest in research in the non-motor symptoms of the disease. She has a special interest in global neurology and the search for innovative solutions to improve the quality of neurological care in low and middle income countries. So I will pass it off to you, Dr. Bruno. Thank you for joining us today.
Thank you. Can you hear me well?
Yes.
And can you see the first slide? Okay, well, thank you and welcome everybody. Thank you for joining this webinar today. And I would like to start thanking the Parkinson's Association of Alberta for inviting me to basically chat or discuss with you about one of my favorite topics and one of my main interests in terms of clinical activity and also research, that is pain in Parkinson's disease. And I would like to make it very interactive. So please, while you are listening, if you have any questions, write them down. If there is anything that is not completely clear, also let me know, because I want you to get the best of these and work together from now on. So in terms of why we're talking about this, I heard many times my patients or even other physicians, family physicians, and even other neurologists telling patients that Parkinson's disease doesn't hurt. And that is a very old-fashioned concept, and it's completely false. And today I'm going to try to convince you about the opposite and share experiences with you. So in fact, what we know is pain is a very common non-motor symptom of Parkinson's disease. And just in case you are not used or familiar with this definition of non-motor symptom, Parkinson's disease, as you know, can have the motor aspects, the tremors, the stiffness, the slowness, but can also have a big number of other issues such as the constipation, the hyperactive bladder, low blood pressure, sometimes some memory problems, among many others. And pain is one of those that fall in the category of non-motor symptoms, and is much more frequent and common than what we used to think in the past. And pain in Parkinson's is in fact a very old problem. If you read the original description of James Parkinson's about the disease that was published in 1817, so more than 200 years ago, you can read that he already mentions that patients that presented symptoms comparable with what we call now Parkinson's disease had multiple pains that he calls rheumatic pains, so kind of arthritis-like pains. So it was there. However, we kind of neglected it for many years as a clinical community. And it was not until recently, I would say in the last 20 years, that we started to recognize it again. And if you see, this graph is the articles, that the research publications that have been published for many years regarding pain in Parkinson's disease. And you can see that until the 2000s, there was very little out there. So less than 20 papers per year. But at that time, when we started to recognize a little bit more of the non-motor aspects of the disease, it started to gain more and more recognition. Now it's a very important topic for us. So when I say common or frequent, I really mean it. About 60 to 80% of patients with Parkinson's at some point have some type of pain. And the pain can be very minimal or can really affect their quality of life, as you probably know. Chronic pain, that is a pain that we define as the one that lasts for more than 3 months, affects up to 20% of the patients at the time of the diagnosis. And in fact, it's a cause of misdiagnosis many times, because you probably heard from someone that had shoulder pain for a long time before starting to show in the stiffness or the slowness of that arm, and had even surgeries in the shoulder until the other symptoms show. So pain can be there even before the rest of the symptoms. But what is more important is that up to 80% of the patients with Parkinson's will have some type of chronic pain during the course of the disease. This means of 8 of every 10 patients will have some type of pain. And if you are here today, I suspect that you know that much better than me. So the most common types of pain appear to be what we call musculoskeletal pains. And those pains are challenging because they may be very hard to differentiate from other pains like arthritis pain or pain due to previous lesions or things like that. And the second more common type of pain that is reported is what we call dystonic pain. And we will go through this while I'm presenting. What is common or what's commonly described is that pain in Parkinson's usually affects the sites that was affected by the motor symptoms in the first place. And what is scary, or it's not surprising, because as I mentioned, for many years, the problem was kind of underestimated, is that just around half of the patients with Parkinson's receive any type of treatment, even if it's just a regular painkiller for the pain associated with Parkinson's disease. And this is related with many factors. For example, it could be related to the fact that patients have the same conception that it's not the Parkinson's that hurts, so they don't talk to the neurologist about it, or even if from the other side, we could sometimes forget to ask about pain, and then that leads to patients being undertreated. The perception of patients about pain in Parkinson's also is very difficult, and it's such a subjective symptom, so we cannot measure it. There's no particular test that we can use. There are some scales, but again, they are subject to a lot of subjectivity, that it's very hard for the community of physicians to have an effective management for this symptom. And again, even as I mentioned that it affects many patients, so it's clinically clearly relevant, we don't have very standardized therapeutic strategies to treat this symptom in Parkinson's disease. For many years, the other problem that we had is that, as I mentioned, it was very hard to kind of assess, evaluate, and quantify pain in Parkinson's disease. So it was not until recently that the first very specific scale for pain in Parkinson's disease was developed. It's a scale that was developed in the United Kingdom in King's Square. It's called King's Parkinson's Disease Pain Scale. And as I mentioned, it was particularly designed and validated for the types of pain that patients with Parkinson's can have. Because if we try to extrapolate or use scales using other diseases like rheumatological diseases, there is a big area that will get lost. So the King's pain scale is now a good instrument that we can use to try to assess pain in Parkinson's. And in fact, we use it for most of our research studies and to assess patients that report pain, and we need to clarify which type of pain is affecting them. There are additional challenges, and as you know, some patients with Parkinson's can develop cognitive issues and dementia. And in those patients, particularly if there are caregivers in this call, as you know, it's very hard to know if sometimes patients are experiencing any pain because the patient may have trouble expressing it. So there are some tools that we can use and scales that we can use to help patients verbalize if they are suffering any type of pain, but it's still a challenging area. So we really need to work together when a patient cannot really express what the feelings are, but we suspect that there must be some pain. For example, if the caregiver is changing or helping with hygiene and there is a painful face with some movements, we really need to explore that. It's something that we cannot just forget about it, because treating the pain may completely change the quality of life of the patient itself. So I think the first question, very important one that we may all have, is what types of pain can occur in patients with Parkinson's disease. And as I mentioned, in the last 20 years, the scientific community has been paying a lot of attention to this topic. And we are still not very sure about how to classify or how to name the different types of pain that affect our patients. So if you ask patients, what we usually get as a response, it can include any type of pain, like aching or burning pains, sharp pains in the nerve territory, tightness, or pain that results from the fidgety movements of the dyskinesia, some inner sensation of restlessness, or even a sharp pain that doesn't respond to any clear cause or doesn't follow any clear localization. So in terms of wording, it's very hard to characterize if one pain is associated with Parkinson's or not, because patients present different types of pain and the spectrum is very broad. In fact, as I mentioned, different researchers have tried through the years to categorize or put names of the types of pain, and we are still working on it. And every year or two, there is a new reclassification. In the beginning, there were 5 categories. Then we learned that we probably couldn't categorize everything in those 5, and there were other types of pain that patients report that would not fall in one special category. And also sometimes patients express more than one type of pain, and the big overlap makes it very hard for us to treat or to help us decide what to treat. So these are all classifications. I tried for this presentation to choose the ones that may be more helpful for you and to help you identify which type of pain affects you and what can we do about that. So as I mentioned, the pain can vary in type and location from person to person. So it's not like some types of headaches where you can say the pain is always in the same spot and with the same characteristics. So it may vary all the time. And the first question that we want to answer is the pain that you're suffering or is related, that you're suffering from, related to Parkinson's disease or not? This is a very important question because we don't want to be missing any other causes of pain that could be treated differently, maybe by your family physician or another specialist. But when you went through all the evaluations and you talked to your family doctor about the pain and it doesn't seem to fit in any other category, then we can try to frame it in the context of Parkinson's disease. So what we usually say is that pain is related to Parkinson's disease, for example, when it occurs along with the first symptoms of the disease. And I put a picture of a shoulder because that's the most classical one. A patient that has, as I mentioned before, a very strange pain in the shoulder. They do many x-rays. There doesn't seem to be anything there, any problem, but the pain continues. And a few years later, they notice a little bit of a tremor, or the physician notices a little bit of slowness. So that is one clue that the pain is probably related to Parkinson's and not secondary to any other cause. Our second clue is if the pain occurs or is aggravated during the off periods. And just in case, I will go through what an off period is very quickly. So when a patient with Parkinson's takes his medications or her medications, there are different periods that we define based on how the response to the medications are. When you first take the pills and they kick in and they start working, they work very well for some hours. We call those hours an on period. When the tremor is reduced, the stiffness and the slowness are reduced, and you can walk better and function better. But as the disease progresses and the medication starts having these waves that we call wearing off or ups and downs, when the effect of the medication is not there, we call it an off period. And it's not uncommon for patients with Parkinson's to be able to describe very clearly what an on period is and what an off period is. So if you have a pain that only appears when your medications are off, so for example, they start when you notice the wearing off, or the pain is aggravated just before you take your next dose of, for example, levodopa, that's also a very strong suggestion that your pain is probably related to Parkinson's. And this is very common, for example, for the pain that appears early morning when you maybe didn't take the medications for maybe 12 hours or 8 hours, if you are not taking it at nighttime, that many patients describe that they have this pain, this like kind of cramping pain in the feet with curling of the toes. That is a classic type of pain that we see associated with these off periods. So again, that is very suggestive. And probably if you have that type of pain, you don't need to be assessed for other causes. The third type of pain that also gives you the clue that is related to Parkinson's and not to something else, if the pain appears mostly when you are experiencing dyskinesia. And again, because not everybody may experience dyskinesia, I will just give you a short description of what that is. Some patients, particularly after many years of the disease, when they take the medications, notice the appearance of some abnormal movements that can vary a lot from patient to patient, but we call them kind of twisting or like kind of dancing movements that can appear in different parts of the body, completely different than the tremor. Those type of movements are called dyskinesia. And dyskinesia can be very mild to the point that patients would not even notice them, or in some very low percentage of patients can be very troublesome to the point that they can produce pain. So if you are trying to stay still and your body, particularly your trunk and your neck, are moving all the time, that may produce pain. So if you notice that the pain appears, particularly when you are having those movements or having the dyskinesia, again, that suggests that probably this is a Parkinson's related pain. And the last clue, and it's one of the most important ones because it kind of helps clarify some of the previous ones, is like, for example, if you wake up in an off period and then you take your pills and the pain disappears, or at least gets significantly reduced, then that's probably Parkinson's related pain, or fluctuation, what we call also fluctuation related pain. And there are types of pain in Parkinson's that respond to the medication, but there are others that do not respond. So this is another clue, but it's not kind of mandatory. So you can still have Parkinson's related pain, even if your pain does not respond to the Parkinson's medication. But if it does, it's also something that supports the diagnosis. So these are very difficult words you don't need to know about, but what I wanted to show with these is that we are learning more and more about what causes pain in Parkinson's, but we're still very far from knowing everything. So we know that the mechanisms are different. Some of the pains are associated with a more nociceptive mechanism. That means that there is some damage or some inflammation that is translated into our brains as pain. There is also a type of pain that is called neuropathic, where there's also something that is wrong or damaged. But the type of pain has very specific characteristics. It's a very sharp, burning, electric type of pain. Like, for example, the one that you suffer when you have a sciatic nerve pain. And then this is a new category, or a new name for an old category that is the last one, that is called nociplastic. That basically means that there is no inflammation or damage, but for some reason the brain creates, or the brain perceives pain, and we don't know exactly why. That used to be called central pain in the past, and was one of the big categories where we have very little knowledge about, and we really need to explore. So again, these are mostly words, but I found this classification would be the one that I would follow to discuss potential treatments with you. Mostly because, as I mentioned, these are the categories or the names for the types of pain that came after the design of the new scale for assessment of pain in Parkinson's disease that I showed you before. So based on the results of that scale, we can characterize the pain in these categories. So the first one is musculoskeletal pain. And as I mentioned, it's a pain that sometimes is very similar to the osteoarthritis pain. It can affect any of the body joints, and it can affect bones or muscles. That's why it's called that way. Then we have a definition of chronic pain. And chronic pain is a strange category somehow, because you basically speak about a pain that is inside or in an organ and that persists with time. So it includes pains that can affect, for example, the bowels, but can also include pains that affect other inner organs that we cannot really define when we're chatting about pain. Then is the fluctuation related pain, and I would say this is the easiest one to diagnose, because as I mentioned before, is that pain that appears mostly when your response to the treatment fluctuates. So mostly in the off periods when you're not taking the medication, or very associated with dyskinesia. Then we have different categories of nocturnal pain. And this is one that if you are experiencing, you need to really talk to the neurologist about it in detail, because there are patients that have nocturnal pain because they're basically in an off night. So they lack the effect of the levodopa. So they find it very hard to turn in bed or to go to the toilet. Movements in the bed are painful. And that has one particular approach. But there are patients that have pain, for example, in the legs while they are trying to fall asleep that could be related with something different. For example, something called Restless Leg Syndrome. So those two things are completely different, and they need to be explored in detail in order to provide the best treatment. There are patients that report the fifth of these categories, that is pain mostly in the orofacial area. So in the mouth and the jaw, mostly. And again, that could be due to stiffness when you are off, like a lot of rigidity in the jaw and difficulties moving the jaw or chewing. But it can also, for example, be related to dyskinesia. So that's something else that needs to be discussed. And there is a syndrome that is called burning mouth syndrome that many patients with Parkinson's also report. That is basically that, for the feeling that your mouth is burning. And that has a completely different approach in terms of treatment. It's different categories related with discoloration of the skin or swelling mostly in the lower limbs. And that we are not so sure about, but it's something that many patients report. So I will chat about that in a second with you. And finally, is the big category of radicular pain that I would say, based on my experience, is the hardest one to diagnose, because many patients in general have issues with degenerative changes in the spine that can produce, for example, sciatic nerve pain. But that radicular pain, when I say radicular, is like a root of a nerve and can go through other parts of the body. That can happen independently of Parkinson's or associated to the Parkinson's. So I would say that's difficult to diagnose, but we have some clues about how to help anyways. So my next question, or I guess is your next question too, is, so, okay, I really feel that I have one of these types of pain. So my patients report that they have one of these types of pain, or when they complete the scale, I can recognize they have one of these types of pain. So what do we do? How can we help? And what you probably don't want to listen, I don't love listening to, is that the truth is that we don't have any solid evidence to recommend one particular treatment. So again, this is related with to what I show you in the first time about the lack of research on this topic for many years, the lack of recognition of the problem. So now that there is more recognition, there are many more studies coming trying to find treatments for the particular types of pain. However, performing studies in pain is not easy for multiple reasons. And as I mentioned again in the beginning of the talk, one of those reasons is that we don't have very specific tools to quantify pain. So it's challenging to design a study that will provide objective data that could be used to produce what we call evidence-based medicine. However, having said so, we have a lot of experience from many physicians through the years that can help us build some recommendations, even if we don't have the highest level of evidence. And it's important to think, whenever I'm going to mention some of the treatments here, that not all the patients are good candidates for all these of the treatments I will mention. Also, the response that some patients may have may be completely different than the response that another patient will have. So it's a kind of a very artisanal balance that you need to reach with your physicians in order to see which ones of these therapeutics are useful for you, which ones may give you side effects that you would prefer to avoid. And again, if one doesn't work, try a different one after. So for that pain that is the most frequent one, the one that affects the joints and can affect one joint or all of them. So of course, in this type of pain, the first thing to do is to rule out other causes like osteoarthritis or a broken knee or a broken shoulder or broken neck. But if all the investigations are normal and you are experiencing this type of pain, the most common thing to prescribe are the regular painkillers, or what we call non-steroids anti-inflammatory drugs. That includes the ones that you can buy in the pharmacy over the counter. In my personal experience, I prefer using acetaminophen because it doesn't hurt your stomach so bad, but we have a maximum dose that we cannot exceed. So it's something that you can chat with your family physician about it. There's no many contraindications for these drugs unless they give you a side effect that is completely not related to Parkinson's. There has been a large trial for the second drug named here that is a combination of an opioid. So this is a morphine derivative and another drug that helps reduce the side effects. These drugs are called oxycodone and naloxone. Unfortunately, the big trial that included more than 200 patients and was performed in Europe didn't show a wonderful result. However, some of the types of pain show some improvement, so it may be worth trying it if your pain is affecting your quality of life. The problem with these drugs, with all the opioids, is that many of the symptoms of Parkinson's can get significantly worse. So we need to be very careful when we prescribe it and how we prescribe it. The same thing if you try a different opioid such as hydromorphone. So the problem with the opioids, even if they may be successful to control the pain, is that they can exacerbate constipation, that is one of the worst problems in Parkinson's. They can exacerbate cognitive issues like memory and thinking problems, and they can also produce hallucinations. That is a very scary symptom that you would prefer, of course, not to have. So it's a very difficult balance, try to manage the pain without affecting the rest of the symptoms. Having said so, many patients tolerate a low dose of opioids very well without any side effects. So I'm not saying you should never try it. I'm saying every single case needs to be evaluated individually. And then there's some evidence for the use of botulinum toxin. I don't know if you were there in my previous webinar, but some types of pain may respond. It's not an ideal treatment in terms of it has to be repeated every 3 months, but if it works for you, it's completely fair to work on it. And then in terms of non-pharmacological or non-medication related treatments, there's some good evidence for exercise and focus physiotherapy to improve these types of pain. I have a patient that recently mentioned that also meditation and mindfulness really help change his perception of pain. So those are non-pharmacological strategies that could be explored. In terms of this chronic pain or this category that is a little bit more diffuse in terms of definition, if it's an internal sensation that is related mostly with the bowels, the first thing to do is address constipation. As I mentioned before, constipation is one of the most common symptoms in Parkinson's. So we need to work on addressing that for multiple reasons that I will not mention all of them, but if you address constipation, you may reduce the pain and also improve your response to the treatments in terms of Parkinson's in general. If that doesn't really make any difference, you could try the previous drugs that I mentioned, like the opioids in very low doses, because if you are constipated again, that may get worse. There is some suggestion that some cannabinoids or cannabis products could help with that. But again, for example, there are reports of patients with Parkinson's having severe psychosis or hallucinations with cannabinoids. So we need to be very careful with those. And then there are some medications that you can chat about with a family doctor that are used mostly for nerve pain that sometimes seem to help patients that have this type of chronic central pain too. In terms of not pharmacological approaches, there are some reports about the use of acupuncture. This is the type of pain that we could do more for. It's the pain that is related with the fluctuations that are normal for Parkinson's disease. So if you start to experience a pain that was not there before, and it's clearly associated with your off times or with your wearing off, or it's clearly associated with the dyskinesias, then you need to chat with your family doctor about options. And the options will be probably optimize the treatment. So as you probably know, we may start with a schedule of medication when you are just diagnosed, but with the years that may need to change in order to help your brain use the levodopa in the best possible way. And sometimes we just need to change the levodopa dose. And other times we may add some additional medications that may help the levodopa give you a more steady response through the day. And that can help reduce the pain associated with these ups and downs. So I've just mentioned some that have been mentioned in the literature, like the patch of one of the drugs that is called rotigotine. Again, not every single patient may be a candidate for that because it may produce side effects that you may be very prone to have. So that's something to chat about with your neurologist. There are other drugs like apomorphine that has been recently approved for the use in Canada that may help when you have very bad off times with pain. So that's something that, again, we are starting to use now in Canada. It seems to be very promising, has been used in Europe for many years. If the fluctuations are very bad, but also associated with your Parkinson's, there can be other alternatives, such as using intestinal shell levodopa or the brain stimulation. That is the surgery that we do for the management of fluctuations in Parkinson's. And there are some other drugs that may be helpful, which has wrote them in the list because they have been named in articles through history. But basically, the most important part here is to optimize your treatment. So whenever pain appears with the fluctuations, it's just maybe saying, you know, you really need to review your meds with your family, with your doctor, because something is starting to need a special attention. And then I mentioned botulinum toxin here. Again, I mentioned it in my previous webinar because this particular type of pain that I mentioned that happens in the morning mostly, but can happen any time during the day. And it's associated with usually curling of the small toes, and the big toe goes up, and sometimes the foot also turns a bit. That can be extremely painful, and sometimes it doesn't respond to medication, and we can use botulinum toxin for that. And we are now conducting a study for that in the clinic, so if you're interested, feel free to contact us. Then I will jump to these nocturnal pains. And as I mentioned, nocturnal pains can be due to do two different things. One is that the patient's, the pain may be related with a fluctuation. And as also I mentioned before, many patients don't take any medications through the night because overall they are doing okay. And the only symptom that they experience is that pain when they try to turn in bed or when they try to stand up to go to the toilet. So if you have that type of pain, that may mean that you may need a little dose of medication at that time to avoid the significant drop in your levodopa levels that may happen otherwise. But there's a different type of pain that is related to what we call restless leg syndrome or periodic limb movements. Patients that as soon as they try to get into the bed and cover their feet with the bed sheets, start to feel this uncomfortable sensation and the need to move the legs that only stops when they stand up and move around. And it can be absolutely distressing. And it can happen in patients without Parkinson's, but having Parkinson's make it more likely to happen. So if that's the sensation that you're having, there are other things to explore, like some blood works that you need to perform to rule out particularly low iron. And there is a particular set of medications that we can use to treat that are not usually the classical Parkinson's medications. So if you feel that your pain may fall in that category, it's something important to chat with the family doctor about, or to the neurologist. Then we have the category of the mouth and face pain. And as I mentioned, there is a syndrome called burning mouth syndrome that is basically that feeling that your mouth is burning. And sometimes it's associated with dry mouth, but sometimes it's not. So there are different formulations of medication, some topical, so you can put them in your mouth, and some that you take by mouth orally that can help reduce that feeling. And if you have mostly a chewing pain when you are off or almost wearing off, that may be more related with the lack of dopamine. So that is something that you should address mostly by, again, optimizing your dopamine replacement therapy. I said that this one is a little bit more controversial or challenging, but I have one particular comment about this. Mostly if you start a new Parkinson's medication and from zero, now your legs or your feet are swollen, or your family doctors notice it, and even the skin changes color a little bit. There are multiple medications that we use for Parkinson's that can produce that. So the first thing to do will be to discontinue that new medication. It doesn't usually happen with the yellow pills, with the levodopa, but it may happen with what we call dopamine agonists, such as pramipexole or ropinirole or rotigotine, and it could also happen with the medication that we use for dyskinesia that is called amantadine. So if you notice that, the first thing to do would be to review your list of medications and stop or try to stop the ones that could produce that. And that may save you a lot of blood works and lots of studies to try to find out if there is a venous or an arterial problem. And it's a pretty frequent side effect. So I would say keep that in mind if you start a new medication and you notice this type of symptoms. And then if you feel mostly a burning pain in your limbs, there are some, again, blood works that need to be done to explore other causes, but there are also some medications like the ones that I mentioned here, gabapentin, pregabalin, and duloxetine, that may be helpful for that type of sensation. And usually are well tolerated if they are started in low doses for Parkinson's disease, and they don't have significant interactions with the rest of the medications or severe side effects. But it depends. You could have a side effect with one of them, and then you switch to another and there's no side effects. So it's something, again, that you should explore with your physician. And then in terms of this radicular pain, or this pain that is more, as I mentioned before, neuropathic, or this burning sensation that has usually a clear nerve, follows a nerve territory distribution. For that shooting pain, particularly in the lower limbs, there are some medications, again, duloxetine, gabapentin, oxycodone, that could be used. But again, I want to remind you that this is a tricky one, because unless it really appears only in the off times and improves with medications, it's very hard to discriminate from the pain that many patients have due to low back arthritis or degenerative changes. So I mentioned mostly medications, and this will be on YouTube. So if you want to take notes to chat about them with your doctors, I'm happy also to provide additional comments if you have questions. But there are many other things that seem to be even sometimes more useful than medications for the management of pain in Parkinson's, or at least for some of those types of pain. So physiotherapy is one of those. And there are different strategies that the physiotherapists may use, like therapeutic ultrasound, using heat or ice, some stretching, some strengthening movements, massages, or some very mild aerobic exercises that are very helpful. I would say it's very hard to design a study to check if it works better than placebo. But most of my patients report that when they are going a good physiotherapist routine, they feel much better in terms of pain. There are some types of exercise like yoga and Tai Chi that are extremely helpful, not just for the pain, but for many aspects of Parkinson's, because basically increase the flexibility and they reduce the stiffness in the muscles. So if you are not doing any of these, I would strongly recommend to try at least some classes online now that the COVID is limiting all our activities, because there is evidence for improvements in balance, improvements in mood, improvements sometimes even in preventing cognitive impairment. And there are programs that are designed particularly for patients that are elder or patients that have some disorders like Parkinson's disease. So it's not a super difficult routine. If you start slowly, that's something that you should incorporate to your life. Also because it teaches you how to breathe or exercise, breathing exercises, and those are also very helpful to improve your relaxation, and relaxation for sure will lead into an improvement of pain. So I am in the Parkinson's Association of Alberta webinars, so I know I don't really need to tell you about exercise. I try to reinforce it every time I see every single patient. Exercise is a real game changer for Parkinson's. And in the beginning, we didn't have evidence, but now we have a big number of articles and papers showing that patients with Parkinson's that exercise have much better outcomes in terms of mobility, but also in terms of cognition and mood and constipation. So I would strongly recommend joining the PAA or any other type of physical activity. Depending on the stage of your disease, you may feel more comfortable just joining Parkinson's focus exercise routine or just a regular exercise routine. It will make a big difference, and it's going to be extremely hard the first couple of weeks. And everybody, including me, wants to give up when we start exercising. But then the benefits are so significant that you will not regret. And then little evidence, but some patients notice it helps. Acupuncture, as I mentioned, for central pain can produce relief of the pain. So again, I don't have a strong research body to suggest acupuncture, but if it's done by very experienced hands and it doesn't hurt and you find it useful, I would say, like, let's go for it, because as I mentioned, what works for one patient may not work for the other. So if this works for you, it's useful to know, and just continue with it. So those are some potential recommendations. There are some other recommendations that are basically related in a different classification of pain, but musculoskeletal and the dystonic, that is the one in the toes, are always there because they are the most common. So again, improving your medications, use some regular painkillers that sometimes patients need to take every day. So not just from time to time. And that's not bad if you monitor for side effects. Opiates could be used with a lot of care because a lot of caution, because they can, as I mentioned, worsen constipation, confusion, and hallucinations. And then sometimes your pain, and I think this is the most important message. Sometimes the pain is just saying that the Parkinson's need better treatment. So again, talk to your neurologist about it because that's a possibility. So my conclusion is pain is a common symptom in Parkinson's disease, and we know more and more about it every day. So it's something to bring to your neurologist consult, as you bring many other issues. Let's just talk about tremor, balance, and you can also talk about pain because it's part of it. Different types of pain may respond to different therapeutic strategies. So it's good to go through the kink scale because it kind of helps you understand where you are standing, but also chatting again with your doctor about this and saying, well, you know, it seems to affect me mostly when I'm wearing off. So maybe there is something related to Parkinson's there. Or if you underwent a million investigations to try to find out what's going on and everything comes normal. And again, as I mentioned a second ago, talk to the neurologist because the pain may be just telling us that your Parkinson's medications need an adjustment or your Parkinson's treatment needs to review. So keep that in mind if you start to experience a pain that was not there before. So with that, I'm finishing. And I want to thank, I'm one of the co-coordinators of International Parkinson's Disease and Movement Disorder Society, Parkinson's Disease Non-Motor Symptoms Task Force, particularly for the subgroup of pain. And we're working a lot on trying to understand more about pain, and some of the information that I put together today is part of the job of a team. So I'm mentioning my colleagues in this slide. And I want to mention two more things. This is where I advertise myself, but it's important for me to try to understand more about pain in Parkinson's. So I'm conducting a big study it involves basically one visit that now, due to COVID, is virtual, with my research assistant or myself, when we chat about many aspects of your disease, but particularly about the pain. So if you are interested in participating, please contact us. This is the phone of our office and the email of my research assistant. And again, it's very important for us to obtain as much participation as possible to understand more, and also to provide treatments that are more individualized and that help patients improve their quality of life. And the second advertisement is not about me, but it's about our team in Calgary. We have a big Parkinson's registry that also has as a main goal to have the information of patients interested in research very handy. So if it's a new study, a new clinical trial, a new therapeutic, or even anything that you could be interested in, we have you in that registry and we can contact you very easily. So if you are not in the registry and you are one of the Calgary patients, I would strongly recommend to contact our research coordinator in that registry too, because again, it's not a lot of time that we're asking from you, and it may help us change the course of the disease or improve our research and hopefully find solutions for patients with Parkinson's and other atypical Parkinsonian syndromes. So that's mostly it from my side, and I'm happy to discuss, answer questions, or any other thing that you, any comment that you may have. Let's start, I will open. Thank you, Judy.
Thank you, Dr. Bruno. We did have a question that was submitted beforehand. Someone asked, how much and how often can you take gabapentin before it affects the person with Parkinson's physically? And they also asked for medications similar to Aleve.
Okay, so in terms of the gabapentin, so it's usually well tolerated. It doesn't, as I mentioned, interact with the Parkinson's treatment. It can produce a lot of fatigue and sleepiness in some patients, not in other patients. So you can take it chronically, like forever, if you have a particular indication at the dose that doesn't make you feel super drowsy or super sleepy. If it makes you feel drowsy and sleepy and you have sleep problems, sometimes what we do is recommend to patients to take most of it at night so they have less sleep without making them drowsy during the day. But again, if there's no particular contraindication for patients with Parkinson's, because we are not expecting the gabapentin to worsen your tremors or your stiffness or your slowness or any of the other symptoms. In terms of the Aleve, so my recommendation, and this is completely personal, is usually to try, we shouldn't mention any brands, but so acetaminophen or paracetamol is the same drug with two different names and has a very common brand name. That's usually what I recommend, and that can be taken up to 1 gram 3 times a day, so every 8 hours. The good part about that one is that in comparison with ibuprofen or naproxen or diclofenac, it has less chances of hurting your stomach and giving you a heartburn or gastritis. But again, some patients like Aleve and tolerate ibuprofen very well. So if that's your case, that works for you, that's okay. But again, many patients don't need one from time to time. They need to take it every day, a few times a day. So in those cases, those medications that may hurt your stomach are not so indicated. Any other question, Emma? And I cannot see.
There's no other questions, but maybe we'll leave it for a minute in case anyone's typing. But it doesn't look like there's any.
Well, again, if you can think about something that was not clear, or you would like information about something else, or again, I would be more than grateful, you would like to help us with our understanding of pain in Parkinson's, the presentation has our contact information, and we will be happy to chat with you. If you are in the Calgary area, it's easier, but if you are also in Edmonton or any other city or place and you need more information, be free to contact us.
Thank you very much, Dr. Bruno. We really appreciate you taking the time to join us and share your knowledge. And I did want to say thank you to everybody who was able to join live today. We hope that you join us at our next scheduled webinar, which is on Wednesday, November 18th, and it is Communicating with a Mask. If you need any more information, you can always visit our website, parkinsonassociation.ca, and all the information will be there. And then this webinar will be shared on YouTube, like Dr. Bruno mentioned. So if you wanted to go back and see any of the information, it'll be on YouTube. Or if you have a question about research, you're welcome to contact your client service coordinator.
Thank you.
Thank you.
Bye-bye.